Thank you very much for the opportunity and the invitation to speak to you all today. My name is Dr. Ryan Cassaday from the University of Washington and Fred Hutchinson Cancer Center in Seattle, Washington, USA. In this talk, I will be covering acute lymphoblastic leukemia in AYA patients. I'm going to break this into a couple different categories, starting initially with Philadelphia chromosome negative ALL and how I approach this disease in adolescents and young adults. Very recently, the American Society of Hematology published guidelines for the frontline management of acute lymphoblastic leukemia in adolescents and young adults. And their first recommendation for the frontline treatment approach states that they recommend a pediatric-inspired or asparagase-containing regimen as a strong recommendation for these patients. So this has now become a standard by many and is now being recommended strongly by this society as the preferred approach for these patients. This trial that has probably gotten the most uptake or focus in the United States and the Americas, I would say, is the so-called C10403 study, which was a phase 2 clinical trial of a children's oncology group-based approach given by adult oncologists to young adults with ALL up to age 40. And at the European Hematology Association meeting last year, Dr. Stock, the primary author and investigator on this study, presented now 10-year follow-up data showing very good durability of the responses for these patients. Particularly if you call your attention to the disease-free survival curve here, these are patients who had an undetectable MRD level after induction. You can see really once you get beyond about 3 years, there have been no relapses or deaths among those patients. Worse outcomes among the PH-like subgroup, but can still be cured in a subset. And perhaps not surprisingly for those who weren't able to complete maintenance therapy, a greater cumulative incidence of relapse. So it's important to try to keep these patients on maintenance if possible. But now with 10-year follow-up in this patient population with very good results, this represents what many feel to be as the preferred strategy for young adults with ALL. But the reality is these are very complicated regimens to give. Some centers are not comfortable giving them. And we don't have very good comparisons against other strategies, certainly not in the prospective setting. And with hyper-CVAD being a very common regimen used in many places, a natural question is, well, how do these approaches compare to hyper-CVAD? And in reality, the outcomes appear to be very similar, at least when you look at this retrospective analysis from MD Anderson Cancer Center, where some patients got hyper-CVAD and then another subgroup got what is called here an augmented BFM regimen. And that regimen is nearly identical to C10403. There are some subtle differences, but it's essentially the same regimen for all practical purposes. So, you know, the true believers for hyper-CVAD could say, well, these are the best data we have and the outcomes were really no different. So why do we need to change? Well, one possible difference in the way these patients were treated is in the era in which this cohort was managed, rituximab was only being added to the hyper-CVAD arm because that was the limitation of the evidence we had with rituximab was a study done at MD Anderson that I'll show in a second. So none of the patients in the augmented BFM arm got rituximab. We since now know that including rituximab with different multi-agent chemotherapy regimens, including a pediatric-inspired regimen used in the randomized French experience here on the left, that outcomes are significantly better with rituximab. The study I alluded to before with hyper-CVAD at MD Anderson is shown here with the blue curve clearly showing better. This was not a randomized trial, importantly, but it clearly suggests a better outcome if rituximab is included. It's an important piece of detail to remember that in both of these trials, the way that CD20 positivity was defined is that it had to be present on at least 20% of the blasts. So it's kind of an easy way to remember since rituximab targets CD20. The other important distinction is that these studies were only for pH-negative ALL. So the best evidence we have for rituximab in ALL is in pH-negative disease. The latest immunotherapy agent to gain traction in the frontline treatment for pH-negative ALL is blinatumomab. And the best evidence for this is the E1910 study, which is a randomized controlled trial of adults who were given an induction and intensification chemotherapy regimen. And then for those that got into remission, ultimately an MRD negative remission, they were randomized to one of two arms shown here in this schema. One arm was given blinatumomab for up to 4 cycles, in addition to the consolidation chemotherapy regimen. And then selected patients were referred for transplantation if indicated, and those that not went on to get maintenance therapy. For those randomized the control arm, they got no blinatumomab, but they got the standard consolidation chemotherapy regimen and went on to maintenance therapy. So what that ultimately means is the patients who got the randomized arm had about 4 to 5 additional months of the more intense or complex phase of treatment. So they got all the same chemotherapy plus an additional 4 cycles of blinatumomab added into that phase of their treatment. But importantly, the total duration of treatment, including with the maintenance phase, was the same. So it's not that the patients in the experimental arm got lots more treatment, and that's why they did better. Here were the survival curves. These are the overall survival data, clearly showing an advantage for the patients who got blinatumomab. But it's important to remember that this is by design, a very distinct subgroup of patients. So these were the 30% of patients who enrolled and were able to achieve an MRD negative remission. So this is a very selected subgroup of patients from whom these survival data were collected. When you think about that, the outcomes for the chemotherapy arm, I think, are somewhat poor, with maybe about 50 to 60% of patients experiencing long-term survival. I would have thought that patients getting chemotherapy alone who got into an MRD negative remission would do a little bit better than that. But why that is not clear. Many now believe, though, that incorporating blinatumomab in the frontline setting for Ph-negative ALL is a standard. But there are several unanswered questions. For example, are there subgroups that benefit the most? How feasible is this at smaller centers or places with less resources? And if patients relapse after this, which fortunately doesn't appear to happen too often, but will that change our ability to salvage relapses if they've already gotten blinatumomab up front? Now, because this is a talk specifically on AYA, ALL, I wanted to highlight these data, which were also presented at the EHA meeting last year. This was a subgroup analysis specifically of young adults who were treated on this clinical trial. So they looked only at the people who enrolled who were under age 40. 120 of those patients enrolled, and 47 were able to be randomized. Again, this was by design because they had to achieve MRD negativity. Among the patients who were randomized, 29% of them were thought to have high-risk disease by molecular features, with 19 having the Ph-like signature. And then the 3 overall survival estimates are quite impressive, particularly for the arm that got the blinatumomab. That's the black arm on this survival curve. No deaths in these patients, which of course is also true for the subgroup of patients who have the Ph-like disease. So if you're able to get into an MRD negative remission and get blinatumomab as a young adult with ALL, the outcomes are exceptionally good with this approach. So clearly, it is something that should be considered for patients able to get access to this medicine, again, if they have chemotherapy-sensitive disease. We have also seen very good outcomes with this sort of approach in a study of standard risk children with ALL from the Children's Oncology Group. They took a slightly different approach. They used their standard risk chemotherapy backbone, which is shown in Arm A and Arm C for 2 different subgroups. I won't belabor the specifics of those subgroups here because they're not so applicable to adult ALL. But ultimately what they did was they incorporated 2, not 4, but 2 cycles of blinatumomab into this treatment backbone for the investigational arm of this 4-arm trial. And ultimately, this study had to be stopped early because of the superiority seen for the patients who got blinatumomab. That's the kind of orange line that got blin plus chemotherapy. So excellent results with adding 2 cycles of blinatumomab to this regimen that already had very good outcomes long-term for these standard risk children. Admittedly, the overall survival differences were minuscule at this point, in part because the follow-up is still somewhat short, but the disease-free survival was so good the study was stopped early. So in a world where we use C10403 primarily to treat young adults with ALL, but the regimen used to show the superiority of adding blinatumomab was with a different approach, it could be difficult to know how to incorporate those data into a pre-existing chemotherapy strategy like C10403. And this is how I have opted to do this. I will admit I'm not sure this is the best way to do it, but this essentially uses the same principles of the E1910 study where 4 cycles of blinatumomab are added in between the different blocks of chemotherapy. But it also taps a little bit into what the COG experience did in terms of how they incorporated it into their approach, because ultimately the C10403 regimen is very similar to the regimen that was used in the Children's Oncology Group study I showed on the previous slide. So essentially, this recapitulates the general schedule that was used in E1910, but with the C10403 backbone. Well, what about hyper-CVAD? So if you are not able to give a pediatric-inspired regimen, or you haven't necessarily incorporated that into your practice for practical reasons or whatever, there have been at least one study that has looked at incorporating blinatumomab after hyper-CVAD. This was a phase 2 trial done at MD Anderson, again, showing very good results with a slightly older patient population than certainly the young adult groups, but it did skew a bit younger with a median age of 37. And this was standard hyper-CVAD, though the dosing for the methotrexate and cytarabine was a bit less than their typical approach. And you can see this was a simpler approach in that they got 4 rounds of hyper-CVAD and then 4 cycles of blinatumomab. There wasn't a back and forth schedule. It was all the chemo and then all the blinatumomab, and ultimately quite good results. But again, a small study done at a single center. Now, switching gears to Philadelphia chromosome positive ALL, this is an area that is rapidly evolving and is getting increasingly difficult to stay ahead of the field in terms of employing the latest data for patient care decisions. So I think for many years, this was viewed as the standard approach for a fit young adult with pH positive ALL. This was hyper-CVAD plus dasatinib. Ultimately with the goal of undergoing hematopoietic cell transplantation in first remission if a suitable donor was identified. And that was the case for most patients on this trial, which you can see here. And the patients who were able to get a transplant are the patients on the blue curve with very good outcomes, considering the historical results with this disease before drugs like dasatinib were available. And for those that weren't able to get a transplant because they didn't have a donor, they had comorbidities or so forth, dasatinib-based maintenance therapy was generally encouraged. And that subgroup included a subset of the patients on the red curve. Some of those patients still got a transplant just with a non-protocol defined approach, maybe an alternative donor or a non-myeloablative conditioning strategy or whatever. But even those patients did fairly well when you think about the historical results. So this, again, was adopted by many and became a fairly typical approach for a young adult with pH positive ALL for many years. But there have been various studies that have come along in the last several years that have started to question some of these components, including the role of stem cell transplantation. So in this multi-center retrospective analysis, a number of patients, over 200, were analyzed specifically after they were identified as having achieved a complete molecular response by BCR-ABL RT-PCR. So they were in a deep remission after receiving hyper-CVAD and some form of TKI. And then they asked whether or not patients went on to receive a stem cell transplant. So this was not a randomized comparison, it's a retrospective comparison. There's lots of bias that could potentially contribute to the outcomes here. But suffice it to say, the survival was no different between the two arms. There is a hint that transplant can still reduce the risk of relapse, but presumably in part because of a greater risk of non-relapse mortality and an ability to salvage relapses when they occur with newer immunotherapies and so forth. This is likely what led to the overall survival really being quite comparable, and similarly the relapse-free survival also. So many point to these data as evidence that we can be more selective in how we employ stem cell transplantation, particularly in patients who got a more intensive chemotherapy-based approach. Another variable that's been looked at is the TKI we are using, and ponatinib has now become increasingly used for adults with newly diagnosed Ph-positive ALL. This started as, in a few different ways, an Italian study that looked at just ponatinib and prednisone, a very good initial results, but many patients will ultimately relapse with this strategy. The MD Anderson group used their hyper-CVAD backbone and used ponatinib instead of the previous TKIs like imatinib and dasatinib. And they've now shown very impressive long-term survival, including 75 years. It's median follow-up of over 7 years now. So very impressive results with very few of these patients undergoing stem cell transplantation. Ultimately, the best evidence we have to support ponatinib in the frontline setting came out from the Falcon study, which was a trial of reduced intensity chemotherapy, but comparing two different TKI strategies. So the patients were randomized 2-to-1 so that more of the patients received ponatinib. The primary endpoint was defined as the rate of MRD negative CR after induction, which was defined both by the BCR-ABL RT-PCR result, but also by more traditional morphologic measures. So you had to achieve deep remission by MRD testing, but also have improvement in your blood counts and no bone marrow blasts and so forth. Ponatinib was given with a response-adapted dosing strategy to try to address concerns about the toxicity of this drug. So everyone started at 30 milligrams, but then once this deep remission was achieved, patients could drop the dose down to 15 milligrams daily, so they stayed at that higher dose for a shorter period of time. Response rates were significantly in favor of the ponatinib arm, with many patients experiencing a deeper remission compared to imatinib. And the survival analyses so far with relatively short follow-up clearly show an advantage in progression-free survival with the ponatinib arm. The overall survival data are perhaps a bit immature. No differences really observed there yet. But this study ultimately was felt to be positive in favor of ponatinib based on these results. Importantly, this response-adapted dosing strategy appears to be effective at reducing toxicities, as the AE rates, including vascular events, were comparable in the two arms. But a critic could say, well, would dasatinib have been a better control? So why was imatinib chosen as the control arm? There were complicated reasons for this that I won't belabor. This was an international study, including some countries where dasatinib is not routinely available. So in truth, imatinib was the only fair comparison that could be used broadly. But while this study was going on, other trials with other strategies were also being investigated, where immunotherapy agents were being brought into the frontline setting. The first of these was the D-ALBA study, which looked at a combination of dasatinib and prednisone in induction, followed by blinatumomab in consolidation. So the regimen is sort of spelled out here, where dasatinib-based treatment is given through about 3 months, and then blinatumomab is added to dasatinib for 2 to 4 cycles thereafter, with 12 doses of intrathecal chemotherapy. Interestingly, the rates of complete molecular response with this approach were not as high as you might expect, and the disease-free survival was a bit inferior among those that had the so-called IKZF1 plus signature. But with a median follow-up now of 4 years, the survival data look quite good, particularly among those that were lucky enough to get into a deep remission. You see 100% disease-free and overall survival among those patients. So it's a particularly good option when considering how this disease preferentially affects older adults. And there's been a second trial done in the US cooperative group setting using a very similar strategy that yielded very similar results. So there's now 2 different prospective studies showing that this strategy is safe and very active. Another approach done by MD Anderson is ponatinib and blinatumomab. So this did not have the sort of induction strategy with steroids for a month and so forth. This goes straight into ponatinib and blinatumomab, a fairly straightforward approach. They used a similar response-adapted dosing with 30 milligrams at the beginning and then reduced to 15 milligrams. Importantly, some of the patients on this trial were actually already in remission when they enrolled. So for those patients, this was really more of a consolidation strategy. But you can see this had a higher CMR rate than the dasatinib-based approach, perhaps because ponatinib is a more potent inhibitor of BCR-ABL. Very few transplants occurred with this approach. And despite that, the survival outcomes are quite good, though even at the latest follow-up of 2 years, they are starting to see a few more events starting to trickle out here. So it'll be important to see how these results bear out over time. And in fact, when they've done a subsequent analysis published last year to try to identify predictors of relapse, they looked at a variety of fairly sophisticated molecular features and so forth, but perhaps surprisingly, having a high white blood cell count was the single most important predictor of relapse in this population. So patients who had a white count over 70 had a very high risk of relapse. Another important pattern with this is that of the 10 relapses observed at the time this analysis was done, 6 of those relapses were extramedullary, with 5 isolated to the central nervous system. So even though relapses may not be that common, they are following a pattern that can be particularly challenging to treat. To try to account for this, the investigators at MD Anderson have actually modified the regimen sort of in the midst of the clinical trial. They've increased the number of IT chemotherapy doses and have incorporated a couple cycles of multi-agent chemotherapy for the patients that have a very high white count to see if that ultimately leads to better results. But the most recent data we have has tried to bridge some of these gaps in terms of these different strategies of chemotherapy, different TKIs, and so forth. And this was a randomized trial that was started several years ago in Italy that looked at comparing the combination of ponatinib and blinatumomab versus imatinib and a reduced intensity chemotherapy regimen for Ph-positive ALL. So these data were reported at the ASH meeting last year. The schema here shows the 2 different treatment arms. I won't go through all the specifics here. It is a slightly different approach than the MD Anderson strategy. And the chemotherapy arm here is a regimen that's a little bit unique to this Italian cooperative group. The use of stem cell transplantation was based primarily on disease features like this so-called IKZF1 plus signature, as well as patients who were unable to achieve MRD negativity. But I want to call your attention to this feature down here where patients who were randomized to the chemotherapy arm, if they did not achieve remission, either by traditional measures or by MRD, they had an option of crossing over and then receiving ponatinib and blinatumomab. So some of the patients on the standard arm did ultimately get the investigational arm via crossover. Now, when they reported these survival outcomes, there appears to be a clear advantage with the ponatinib and blinatumomab based combination. Those are the blue arms, the experimental arms. And you can see the event-free survival is excellent, significantly better than the yellow arm, the control arm. Similar story for the overall survival. Interestingly, though, the group that had the best outcome, not statistically better, but numerically the best, were the patients who crossed over. So these are the patients, again, who did not have a very good result with the chemo and imatinib arm, and then switched to ponatinib and blinatumomab. So the gray line here actually yielded the very best outcome of all. And this included a number of patients, again, who didn't have a very good response. A number of them went on to get transplant, so it's a bit hard to know exactly what contributed to these outcomes. But it does raise some interesting questions about truly what the optimal strategy is for these patients. So, when I look at these data, which again have not been subjected to peer review, this is just the presentation at ASH last year. One question is, well, what if ponatinib was used in the control arm as opposed to imatinib? So, when this trial was designed, again, imatinib was considered a standard. So that was the control arm. We have since now know that ponatinib is superior to imatinib. Is it possible that if the randomization was truly just chemo versus blinatumomab, we wouldn't see quite as big of a difference? I suspect the blinatumomab is improving outcomes by some measure, but exactly how much is hard to know. Why did that crossover arm do so well? When we think about crossover designs in oncology trials, usually those patients don't do as well. But it raises a question, is perhaps a hybrid type of approach the best? So in other words, you start with chemotherapy, but use ponatinib. And then after patients get into remission, then switch them to a blinatumomab-based approach, kind of like what we do now for Ph-negative ALL. And maybe that would also address concerns about extramedullary relapses and so forth. And then lastly, about 20% of the patients on the ponatinib and blinatumomab arm got a transplant in first remission, and we don't really know what benefit that provides. One of the advantages of the hyper-CVAD based approach are the data suggesting the transplant can be deferred if you get into a deep remission. So how transplant is used in these regimens is still unclear. Just to talk a little bit more about this concern about extramedullary relapses here, this is from a review article that was presented in the educational session at ASH last year, speaking to this concern about a possible increased risk of extramedullary relapses with these chemotherapy-free approaches. I won't go through all the details here, but considering how extramedullary relapse historically would be seen in maybe 5 to 10% of relapses, the fact that we're seeing this in 30 to 50% or so of these chemotherapy-free strategies suggests that, on the whole, fewer patients are relapsing, but those who do have particularly challenging forms of relapse that we'll have to address. So how do I currently treat young adults with ALL, to sort of summarize? So for pH negative disease, I generally prefer a pediatric inspired regimen. I'll still use hyper-CVAD if I don't think that's going to be feasible or safe. I'll add rituximab for cases that are CD20 positive. For patients with T-cell ALL, I will consider including nelarabine if I think they have a high risk of CNS relapse. I didn't show a lot of the data there, but the advantage with that drug appears to be at reducing CNS relapse, in my opinion. And the decision to transplant is based mostly on their MRD status. If they're MRD negative after 3 months, I usually will defer transplantation, include blinatumomab as consolidation, and so forth. The two exceptions to that are KMT2A rearranged ALL and ETP ALL. Those patients I'm generally still recommending transplant. For pH positive disease, I'm typically recommending hyper-CVAD and ponatinib. I'll defer transplant up front if they can get into a deep remission as discussed. And while I'm impressed with the chemotherapy-free strategies, I'm a little skeptical about using them in young adults. The follow-up is still kind of short. I don't love the extramedullary relapses. And when you think about it, these patients generally do quite well with chemotherapy, so I don't necessarily think we're making it all that much safer. In terms of specifically using blinatumomab, we now have 2 randomized trials showing that this is advantageous. It appears to, have the greatest impact for younger patients. It's not very easy to operationalize, but I showed a couple strategies where it can be done practically. And for those that are MRD positive after chemotherapy, it's still a good option to deepen remission and hopefully facilitate transplantation. For pH positive disease, I'm now starting to incorporate blinatumomab as consolidation for those that achieve MRD negativity, kind of based on the Gemema Italian study that I showed before. I'll continue the TKI that they were on. Again, I kind of like this hybrid strategy because I think it sort of addresses some of the current issues, but I'll admit the follow-up is sort of short, and we don't really know for sure that one strategy is going to be better in the long term. By incorporating blinatumomab, I'm sort of extrapolating from the pH negative data showing how blinatumomab is helpful, but I still think MRD positive patients probably benefit the most from blinatumomab, particularly to facilitate transplant. The last couple of minutes, I'll talk about practical challenges of treating ALL, which I think get a bit emphasized, particularly for young adults. When we think about how these patients come into our care, this is true of the United States. I'm sure it's true of other centers as well. There are many different ways that these patients enter our medical systems, and then they often have to be shuttled through referral centers, outpatient centers, local clinics, etc., emergency departments, urgent cares. It can be quite complicated to keep track of where they are and where they're going to go. And these can often also include large geographical barriers that you have to consider. So if a patient is hoping to go closer to home after they're initially diagnosed and sent to a referral center, you have to be sure that the treatment you start is something they can feasibly do, whether it's at that local center or coming back and forth. And for a young person who is trying to want to do everything possible, that could be very challenging. They may not have the financial security to do it. They have greater impact on their caregivers. So it's an important thing to think about when choosing a treatment. Is it going to be portable with them if they go somewhere else? This also raises interesting questions about the financial challenges of using different immunotherapy options because these drugs are very expensive. A lot of these patients end up in the hospital, so the drug has to be given in the hospital for monitoring purposes and so forth. And this can be very difficult from a reimbursement standpoint, at least the way that drug reimbursement is done primarily in the United States. But it also is important from a practical standpoint because sometimes these drugs are not routinely available in a hospital, particularly if it's a smaller hospital. So you have to think about this when making decisions about, talking to patients and making and thinking about the practical challenges, particularly with blinatumomab. It has to be given as a continuous IV infusion. There's driving restrictions. It might extend the duration of treatment, which can be very difficult. And we don't really know what the optimal number of cycles of blinatumomab is either. Maybe 2 is enough, but we don't really know. They are trying to address this by formulating a new subcutaneous version of blinatumomab that's currently under investigation. It's able to achieve concentrations that are higher than what the continuous IV formulation achieves, but the toxicity rates with this drug are not trivial in experience so far. High response rates and relatively good survival. They are now enrolling into an expansion cohort that might ultimately lead to the approval of this agent, but we'll have to see if that bears out. So with that, I want to thank you all again for your attention, and it was really a pleasure to talk to you about adolescents and young adults with ALL.